We're going to look at proper infection control techniques and concepts in the dental setting, from the front desk to the operatory. We want to focus tonight on emerging diseases and give the clinicians systems and tools for preventing contagious diseases in the dental setting. As we look at our goals tonight, I hope that you're going to be thinking about the action words that belong with these goals. Identify, establish, and describe are the action words, and I hope you'll be able to identify proper infection control techniques before we're done here, and be able to establish a protocol for the use of hospital-grade disinfectants in the dental setting. We all have to be able to describe the steps necessary to prevent that chain of infection and to make sure all of our staff is educated and trained in this part. Our goal here, the first goal we're going to look at, is to describe the steps necessary to prevent the chain of infection. But what is the chain of infection and how does this work together? Although your work may increase your risk of getting some diseases, a number of procedures used routinely in the dental setting help keep that risk to a minimum. Infection control strategies break the chain of infection. Through vaccination, hand hygiene, careful handling of sharp instruments, barrier techniques, and proper cleaning, especially focusing in on disinfection and sterilization procedures, you can have the safest workplace possible. You know, when we look at this, sometimes we make it a very, very complex set of things that need to be done. But I'd like you to take a minute and break this down, and I hope that this is something that you as a staff are going to look at carefully. We've got 6 things that we have to be looking at when it comes to the chain of infection. What is an effective infectious agent? The bug that causes disease. Where's the reservoir in your office? Do you know the places where that bug can be reproducing? Are you thinking about those areas in the office? We'll look at those closely today. Have you identified the portal of exits that could be happening that can leave the reservoir? Are you looking at the mode of transmission? Where in your office could this be taking place? Are you preventing the mode of transmission? The portal of entry, this is things like sores on people's hands or people that have overwashed their hands and ended up with a drying agent or cracking or peeling of the hands. And most importantly, and the one that I think you as dental healthcare professionals have the most control over, is that sick patient. A sick patient who's unable to fight a bug, but also the sick clinician or the clinician that doesn't have the immune system to handle being exposed to different bacteria and viruses. So a susceptible host, this is where the dental professional, in my opinion, has the most control. Keeping yourself healthy can impact both you and your patient. We can do things to keep ourselves healthy, including vaccinations, diet, exercise, stress reduction. And I did have a dentist tell me he's going to have to quit his job if he's going to get stress reduction. I don't want you to quit your job. I want you to look at some simple things you could be doing in this setting. All of these impact our ability to fight off disease. This is a wonderful little chart that the Centers for Disease Control came up with for us to remember the simple things that we could be doing within the community. This is a public health chart. So increasing antibiotics actually decreases host susceptibility. Looking at better nutrition, making sure that we take antibiotics when it's appropriate and not inappropriate, will help us strengthen our immune system. Better nutrition can make it so if we are presented with a disease, we have the healthy lungs, the healthy skin, the healthy tissue to fight it off. Better housing, safer food and water, and I got to tell you, in the dental setting, sometimes that safer food or water can be a major issue, as I see people bringing food into the operatory or bringing personal protective equipment into the area that is designed just for taking care of food. Immunizations and improved hygiene and sanitation. We'll look closely at those today. All of this can decrease not only host susceptibility, but disease transmission. Let's take an example here. One of the examples that you might not think about in dentistry. 94% of all C. diff in the country is related to healthcare in some way. I want you to think about that for a minute, because you might be thinking, I'm in dentistry, how are my patients going to end up with C. diff, which is something that happens in the intestinal tract. It's people end up with a diarrhea that just won't stop. A majority of those at risk from the possibility of this deadly diarrheal infection have taken antibiotics and have received medical care in any setting. With C. diff in the United States, last year they were able to attribute 14,000 deaths to this disease. If a patient comes in with these symptoms, we're not going to see them. But yet how many times do we say, oh, come on in, it won't be a problem? We are going to refer them to their health care provider unless it's an emergency. So how do we get that into place? Have we trained our staff to know what it is they're supposed to do when they make that phone call on the phone to confirm a patient? And let's step one step further back than the receptionist job. Have the dental health care providers in the chair said to people ahead of time, you know, if you're not feeling well, will you let us know before you come in for your appointment so that we can schedule properly? It starts with us. We make the difference. The risk of patients getting C. diff is increased 7 to 10-fold while patients are taking antibiotics. And over the month following the discontinuation, which surprises a lot of people, even after 2 months, the risk continues 2 to 3-fold. The American Dental Association and the Centers for Disease Control have asked all healthcare professionals that prescribe antibiotics to use them judiciously, to make sure that they are looking at who they could be impacting. And I love this picture that came from the Center for Disease Control. They've got a lot of pictorials right now that you can download off their website. This is a great resource for all of us. This is going to show us what it is we can be doing to prevent the transmission of disease. We want to be aware that when we take an antibiotic, it disrupts the normal flora within our intestinal tract. And we may get a proliferation of C. diff. Some people can be carriers, some people it can go into a very risky situation. Learning about that and teaching all of our staff about the signs and symptoms to look for is one of the core elements of a good infection control policy. This poster right here is something that you can hang up in your office to remind everyone why it is we don't want to be giving them antibiotics unless they really need it. Simple concepts such as how many people have ended up in the hospital, how many deaths have occurred within a year, and how many people are ending up in the hospital for long term. We want to keep people aware and make them part of the solution. I love right here where it shows us how it could be spread within the setting and what we need to do as healthcare professionals. And this is something you may want to download from the CDC and use in your staff meetings to educate all of your staff. So how do we look at emerging infectious diseases? What is it that we have to be aware of when we're dealing with these diseases? Remember that an EID is an infectious disease that is newly recognized as occurring in human beings, but one of the things that a lot of people don't get in this with these diseases is they may have been around for a while, but they may be affecting new people, or they may have changed slightly and be more contagious or develop new attributes. As we look at the different diseases that have been emerging diseases and are the leading cause of death, let's look closely at this for a moment. This is the statistics from the Center for Disease Control. And within these statistics, you can look as far back as 1950 as we look at this. And this is a great chart for us to see some of those leading causes there. I hope all of you are going to start looking at this and thinking about how you could be contributing to part of these diseases by the choices we make in what we're doing in dentistry. Are we getting our vaccinations when it comes to influenza and pneumonia? Are we looking at the fact that if we choose not to do that, if we have any sign or symptom, And we cannot come into the dental setting because we're going to be treating patients with contagious diseases. I'd like you to look at influenza. It's come a real long way, and I think that's an important thing for us to keep in mind, that influenza has changed over the years, that we have had a decrease in the amount of people that have died as a result of influenza. But it could get better, and that's what we can do as healthcare providers. Now, all of us got to hear a lot about this disease, Ebola. It made the national news. I don't know how many patients called me and asked if they could cancel their appointment because of what they heard about this spreading in the dental setting. Remember, I want you to kind of step back for a minute and compare this emerging disease to some of the emerging diseases that we need to be more aware of, including influenza. 9 out of the people contracted the disease outside of the U.S. and traveled into the country. Kind of neat tonight. We have people all the way from the United Emirates to the United Kingdom to Thousand Oaks, which is just a few miles away from me, who are on this call tonight. And I think that is so fantastic because we're here as a team trying to get better, trying to choose one thing that we can do in dentistry to make it a safer environment. 9 of the people who contracted this disease outside the United States and traveled into the country, either as a regular airline passenger or as a medical evacuee. We have only had 2 deaths in the United States. The other 2 cases that occurred in the United States were nurses, and they both recovered from the disease. There's simple things that have been put out into the public that we need to be looking at in order to keep people safe. This wonder pictorial that came from the Centers for Disease Control gives us the things that we can do to help prevent this disease. And yet, how many of us are paying attention to that when we think about influenza? Only counting the deaths where influenza was included on the death certificate would be a really gross underestimation of how this disease impacts us. The CDC does not exactly know how many people die from seasonal flu each year. They have to do an estimate. There are several reasons for this. First, states are not required to report individual seasonal flu deaths of people older than 18 years of age to the CDC. Second, seasonal influenza is infrequently listed on death certificates of people who die from influenza complications. They'll list things like pneumonia or other causes. Third, many seasonal flu-related deaths occur 1 or 2 weeks after the person's initial infection, either because the person may have developed a secondary bacterial infection, such as bacterial pneumonia, or because seasonal influenza can exacerbate a existing chronic illness, such as congestive heart failure or chronic pulmonary diseases, and they'll list those as a death. Also, many people who die from seasonal flu complications are not tested for the flu, or they seek medical care late in their illness. As you can see, there's many reasons that we might not even know that these deaths, this disease is considered the disease that is the 7th leading cause of death in the United States. So why aren't we paying attention to this? Why aren't we all running to get the vaccine that we need for this disease, or do all the precautions that we can? You know, we're required on the side of our box of masks, it has the number 2 with a slash through it. And that slash reminds us that this is a single-use product. You heard me. That mask that you keep putting in your pocket and pulling down on your chin and wearing as a chin bra, it is required to be used only one time. Primary methods used to prevent occupational exposures and to transmit disease have to be focused on. So we've got some controls that are already in place that were given to us by by OSHA, who is over the employee, but they give us some really great things that we can do. The primary methods used to prevent occupational exposures to blood in the healthcare setting include standard precaution, engineering controls, and work practice controls and administrative controls. Engineering controls that eliminate or isolate the hazard are the primary strategies for protecting all dental health care professionals and their patients. When engineering controls are not available or appropriate, I wish we could put people in a plastic bubble, but it doesn't always work. Work practice controls that result in safer behavior and personal protective equipment can help prevent the exposure. Administrative controls are the policies and procedures that reduce the risk of exposure to certain diseases, such as influenza. Healthcare providers. Any healthcare provider with flu symptoms, according to the CDC, should isolate, stay home, and get well. And I have had so many offices that I go into that people are coming to work sick. Not only are you not supposed to come to work sick, but you are not supposed to come to work for 24 hours after you no longer have the fever without using medications such as acetaminophen. Those with ongoing respiratory symptoms should consider for evaluation before they come back to work. We have to make it the policy. That is the administrative control. The Center for Disease Control in their 2003 guidelines on page 8 and 9 have wonderful guidelines for you to hang up in your office and remind when people can come to work and when they cannot come to work. With patients with influenza or influenza symptoms should not be seen for elective treatment. And yet, the last time I worked in the dental setting, a few weeks ago, I had a patient come in and say to me, I knew that I was going to not be able to get an appointment for a few weeks, so I decided to come in anyways, even though I have a fever. We have to think about who we're putting at risk, and we have to train our patients. So what? Again, early identification. Page 8 and 9 of the MMWR from 2003 has that wonderful chart for you to hang up in your office. If somebody does come into the office sick, we want to promptly isolate them. And then we want to do the appropriate treatment. If someone's in pain, we're going to have to help them get out of pain. But preventative treatment can be postponed. Remember that we are all part of a herd. I love this. A sustained transmission. This principle of underlying herd immunity is that the presence of enough immune persons in the community interrupts the transmission of an infectious agent. And each of us, if we go and we get our vaccination, we're going to be part of that herd that is making it so that you are not susceptible, you're immune. But what's your part? Where are you today? What are you creating? Are you making other patients more susceptible to disease? Many studies have shown that bacteria that cause hospital-acquired infections are best transmitted through hand-to-hand contact. And I love this little poster here because it says 88% of disease is spread from hand-to-hand contact. And why I want you to see this is because I want you to realize that part of what we have to do is to remove debris before we can get rid of that bacteria. This is a microscopic picture of an oxygen bubble on someone who has washed their hands. That oxygen bubble bursts and it actually is able to kill bacteria too. So the lathering principle, it's an important part of what we do when we wash our hands. So there is one area that you have a lot of control over when it comes to emerging diseases. That is hand hygiene. Remember that OSHA and the CDC say that proper hand hygiene must be performed by dental health care professionals before and after contact with the patient. So before you slip on that glove, you have to have taken care of your hands. After you slip the glove back off, you have to take care of your hands. Their body's substances and items contaminated by them before and after performing invasive procedures, before preparing, handling, or serving or eating food, and that, for those of you in California, that includes See's Candy. So when we look at the triclosan study, when they were looking at soap and water, we discovered that they can reduce disease transmission by 50%. 95% of you are out there saying that you are washing your hands. And in the study, in the dental setting, 67% of you actually do. There are other studies that show it as low as 30%. Problem is here that 33% of you are using soap and only 16% of you are washing long enough. Some great studies out lately on why it's important to dry with a disposable paper towel afterwards, because that's going to remove about 23% of the bacteria that is removed in this process. So what are some of the reasons that people are not washing their hands the way that they should? What they discovered with nurses, there hasn't been a study yet in the dental setting that I could find, but what they discovered with nurses was the heavier their workload, the less likely they are to perform hand hygiene. I hope that you're going to look at your staff and you're going to come up with a system for reminding each other. One of the things that we do in my practice is we rub our hands together gently if we see someone who has not washed their hands. That way no one has to offend anyone, the patient isn't aware, but if someone walks in the room and starts to work on the patient and hasn't washed their hands, you can gently rub your hands together to remind them. Simple things that we can do to keep each other safe, to care about each other, to make things happen. You heard earlier that we had some things that were important. We had administrative controls, engineering controls, work practice controls, and we had personal protective equipment. I hope as you look at this that you'll think about some other things that have been equally or more effective. Remember that personal protective equipment is the last line of defense. Elimination, and that's where when we get someone with a contagious disease coming into the dental setting, we want to make sure we're eliminating disease. And I want to thank Olga at the Free Clinic, because she asks people who cough on the phone before they come in to the dental setting, how long have you been coughing? And if they tell her they've been coughing more than a week, she says, have you seen a healthcare provider? And we have an increased rate of tuberculosis across the world. And I hope that we're all thinking about that, because if we can start asking questions, have you had night sweats? Have you lost any weight recently? All those things that go with TB, if we can eliminate getting this into the environment, think about what we could be doing for our community. Substitution, that's looking at things that replace the hazard. Engineering controls, isolating people from the hazard. Administrative controls, well, that's in the orange area. It's not giving us everything we need, but helping to change the way people work. We're going to look at that today as we look at choosing a disinfectant, and we look at how important it is to train your staff how to use a disinfectant, to make sure you're all on the same page and using it according to manufacturer labels. And then again, the last one in place is that personal protective equipment. That's kind of like the stopgap, the thing that's going to protect you if the other things don't work. So what is it that we're trying to protect against? What are those agents that we might be concerned about? I want you to look at those for a minute as a staff or as an individual and think about them. Bacteria, viruses, protozoan, parasites in the dental environment, fungi, spores. Some of those we may see in the dental environment and some of those we may not. When we're choosing a disinfectant, we have to say, which one of these things am I more concerned about? Would I be really focused on C. diff, where my job with C. diff is to make sure I don't give antibiotics, not necessarily that this is going to be transmitted in the dental environment. So we've got to root out which things we would be the most concerned about. So let's look at some of those for a minute. The first word that we want to look at when we look at these is viability. Viability means how long is this going to last on a surface? When we put this on a hard surface in a nice room at the right temperature, how long will it last? HIV for hours. Rhinovirus, that wonderful thing that gives you the common cold, 14 hours. Staph, kind of a concern for the dental environment, 5 days. HPV, which used to be the disease that we knew could be transmitted in the dental setting. I will say with HPV it's gone down incredibly since you've started getting vaccinations and you've been using universal and standard precautions. But it can last on a surface for up to 7 days. We have our first case of HCV being transmitted in the dental setting that we know of in this last year, and it is a concern. HPV in the dental personnel has gone down to the point that we are 1% below the general population. And I want to give you a round of applause on that. That's because many of you are wearing the proper personal protective equipment and have been vaccinated against this disease. Now, TB can last on a surface from 6 to 8 months, pretty long period of time. And the reason that we use TB as one of our marker cells to determine are we going to use this disinfectant or not use it is because the length, how hard it is to kill this disease. It's not that it's easily transmittable, because it is a harder disease to transmit, but it's very difficult to kill on a surface. Again, with HCV, it lasts 16 hours to 4 days, depending on the study that you look at. And MRSA is one of those things that we've seen an increase in the dental setting and the medical setting. That is something that can last up to months. So how are we going to prevent this from moving on? Again, the Center for Disease Control and OSHA say, well, OSHA making the must statement and Center for Disease Control giving us those recommendations, that we must wear a surgical mask that covers the nose and mouth during dental procedures. The part I wanted you to get on this is look at all those areas that we want to focus in on. The splashes, the sprays, the splatter, the blood, the saliva. You guys are sitting and spit almost every day. The mask must be changed whenever it becomes contaminated or wet and between patients. There's a couple of really good studies that go into if you're working with something that involves a lot of water, like a Cavitron, you're going to be changing this more frequently. You're going to change it about every 20 minutes because it turns into a wick if you're not using it properly. So what are we looking for with this? All of you probably already know this. We want it to fit the face. We want there to be no gaps. Please do not twist the elastic band to create a gap on the side, because you just defeated the purpose. The purpose of this is to get 95% filtration. That's a medical mask that's approved by the FDA. And you want to see over there on the side that I put this is going green. The reason this is going green to change your mask, to make sure it's got 95% filtration, you're not buying it at a drugstore, you're getting a medical FDA approved product, is because I don't want you to end up in the hospital. If you've just ended up in the hospital, how many masks are they going to be using there, and how many sheets and how many blankets and how much medication? We've just defeated the purpose if we think we're saving money. We want to change this between every single patient. This picture right here I absolutely love. This is one of my dear friends, and she let me take a picture of her like this. There is no point in having a mask on if you're not going to cover your nose. This one, I hope you're not out there right now. This was a great advertisement picture for an office, and I call this a chin bra. He is not wearing this properly at all. He has his patient very well protected. He's got the wonderful eye protection on the patient, which I would really encourage you to do. But he's got no eye protection on himself. He doesn't have his arms covered with the right sleeves, and he's wearing a chin bra. So what is preventable, and where can we help? Where is it that the dentistry needs to make a stand? We need to make a stand about contagious and transmittable diseases, about bacterial infection and viral-based diseases. We need to really look closely at antibiotic-resistant infections. That's what we have to be doing to keep the patient safe. I hope that you'll set a protocol, that your receptionist will start asking the questions. Has anything changed with your health since you came in last, before the patient arrives at the office? Have you had any recent illnesses or contagious diseases? Have you had any hospitalizations or recent surgeries? Those simple questions can save you the time to reschedule a patient when they show up at the office and you're not able to treat them. But what else can we do to prevent these things from happening? How is it that we can have checkpoints to make sure that we're doing the right thing? I hope that before we're done going through these, that you'll be able to identify the proper infection control techniques in the dental setting to prevent contagious diseases. So I love to go into hospitals and look and see what they're doing, because I feel like in dentistry, sometimes we're not staying up to date with what we should be doing to get across that we have been effective in keeping a room clean. What this is right here, they use this in the hospital. They use it in the rooms where patients are sleeping. They use it to check nurses' hands. They use it to check the operating room. This is an ATP meter. and it's a cleaning verification tool. The ATP meter measures molecules found in living cells. I love this because this is going to show me, have I done what I need to do to make it safe for the next patient that's coming in the room? So what we're looking for is higher RLUs. That means that there's higher contamination. So what is an RLU? It's bioluminescence reaction of the amount of ATP present, and ATP relative light unit. What we're looking for here to pass is less than 10, caution 11 to 29, and fail is a 30 and above. The pictures that we're going to see in a few minutes, I want to thank the office that was willing to let me take pictures. I have now been in 121 offices to do this testing. You're going to see the average between all those offices. So we're not going to be seeing this particular office, but rather a conglomeration of the numbers. We're going to get what the median was here. So let's look at what we're looking at here. Remember, infection control is not static. As we learn new things, maybe you learned something a few minutes ago, like that you should be thinking about what antibiotics you're giving a patient because it could, especially in an elderly patient, lead them on to C. diff. Maybe you're thinking about how you need to be washing hands or how you wear a mask, one per patient, because it is built in to the FDA regulations. Remember that a mask is an FDA regulated medical device. Progress is impossible without change, and those who cannot change their minds cannot change anything. So I hope as we go through these slides, you'll think about some things that maybe you could be changing. Maybe you can identify one area in your office. Welcome to your office. Now go home. Sick patients should not be seen for elective treatment, especially surgical procedures. Screen on the phone, screen at the front desk, and screen before the patient even leaves from their last appointment. Teach patients to know when they're not supposed to come in. If someone has a cold sore, which is a herpetic lesion on their lip, should they be in the dental setting? I'm going to give you a minute to think about that for a second. Should someone with a cold sore, which is a herpetic lesion, be coming into the dental setting? Well, the answer is yes, and the answer is no. They may be coming in so that you can use your laser to wave over it and help that disease to get under control quickly. Or the answer is no, because they have elective treatment scheduled and you could be exacerbating the disease. You could be making it worse. Or in the studies that came out of the United Kingdom where a hygienist had herpes whitlow on their finger and actually gave it to the patient. We have a responsibility to keep people safe. So let's look at some of those outcomes within those offices. Where was the dirtiest place in the office? Remember, we're going to talk about from the minute they come in to the minute they leave. The dirtiest place in your office was actually the front desk, with an average of 184 RLU. Remember, this is normally a housekeeping place. In other words, we're not going to be using a hospital-grade disinfectant until the patient contaminates it. As I watched in many of these offices, what I see patients do is they come to the front, they take the cotton gauze out of their mouth, and they plop it on the counter. When that happens, this now becomes a clinical contact surface. Then you will need to be wearing personal protective equipment, including utility gloves, and using a hospital-grade disinfectant. That area is an area for all of you to stay safe. The people in the back have that personal protective equipment. The people working in the front don't. So we've got to keep people safe. Second place we're going to look at, this is the patient service table. In some offices, the average came out to 116 and after 118. But in some offices, this was actually one of the dirtier places in the office. Remember, we want to make sure that we're keeping this place very clean because this is where we're going to be putting items that go directly into the patient's mouth. The countertop next to the computer in the operatory, before 111, after 89. I really want to encourage you to think about that counter. Remember that from the patient's head to 6 feet out is where we know overspray can go with a high-speed drill and with the ultrasonic. So this needs to be treated like a clinical contact surface. This is an important area. Under the tray, and you'll see that I chose an area here that was you'd think maybe you don't need to be cleaning. Under the tray, 217 and after 66. Now, you saw that that first slide was 186. The reason that this got so high was because of a couple of particular offices. So if we took the average of those ones out of there, this wouldn't be the dirtiest place in the office, but this is a place for you to be really thinking about. And then consistently high ATP before, do not touch this barehanded. It happens to be those holders for the unit itself. So those holders before 318 and after 110. So there's some people that aren't cleaning this properly. We're not getting anywhere close to that 10 that we want to get to. This is a place where you may want to be using barrier protection. This is the top of the patient delivery tray before 116, after 16. You guys are doing a pretty good job with this, getting that particular area taken care of. Really want to encourage you to look at those other areas that we looked at that some people might be skipping. Countertops in the operatory, an average of 168 before and 121 after. Again, I think this is an area that people are skipping. What we did discover in comparing the pictures we took in different offices was that the offices that were highly cluttered and had things like models or pamphlets or things on the counter had the higher numbers of ATP. And if you look at anything from hospitals, they say that clutter holds ATP. So get those things off the counter, put them in a drawer, take them out when you need to use them, and then put them away. Some other things that we learned as we were going through the office is that we need to be really thinking about how we're going to protect each other, where we need to be focused in on. This is in an office, and I want you to note what she's wearing here. Few things are missing, and I'll let you stop for a minute and think about what's missing and what some of the errors could be in this area. Maybe you can talk to each other and share what you see there that you're a little concerned about. Well, the first thing that I see is she has no safety glasses on and she's working in the sterilization area. Please, 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 I'm going to encourage you all to go on to Jen's Vision, jensvision.com. It's a patient who lost the sight in her eye because nobody offered her safety wear to wear. And this young lady is in that same risk. Remember, when we're in there and we're removing an amalgam and that drill is going 50 miles an hour, a little tiny piece of amalgam could make a huge difference in someone's life and quality of life. The second thing is she has no utility gloves on. She's wearing patient exam gloves. And I don't think she's going to be examining any patients back there. You need to be wearing utility gloves anytime you are done with patient care, that you are touching chemicals or working with sharps. No patient exam gloves belong in this area at all. Personal protective equipment. In some of the offices I saw in the area where people were supposed to be eating, that they were hanging their personal protective equipment there. Remember that personal protective equipment cannot leave patient care areas. This is supposed to be the lunchroom, and they've got the laundry right in the lunchroom. Something for all of us to keep in mind. That room should be sacred. It should keep all of you safe. Remember also that we're supposed to cover and store covered items in the sterilization area. Again, with the ultrasonic, if the lid's off, it goes 6 feet out. With the lid on, it's about 2 to 3 feet if the front of it's wet. So since 1989, we were supposed to be covering the items that have been processed. I've been asked a lot lately, is it still necessary to date the packages? It is necessary to date the packages if you don't want to have to pull every single item out of the area if you have a failed load. So keep dating those items. The other question I get frequently lately is how long is it before we have to re-sterilize things that have been in storage? The CDC is now saying that that is incident related, which means did it poke through the package? Did the did the item no longer have what it needed to stay safe? We want to remove clutter. You'll see here in this area right here, we've got a mixture of items that are paperwork, items that are gloves, items that are going to be going to the lab, all mixed together. The lab area should never, especially when we've got a lathe there, should never have papers around it. What else do you see in here that needs to be changed? Can you see that they've got a phone right next to where they're working with laboratory equipment? The overspray from that lathe could hit the phone. These are some items that you're going to want to get off the shelf. Remember that tip that goes with that dispenser right there, that should be replaced for every single patient, and there's a cap that needs to go on there. And notice that it's touching the floss dispensers. The floss dispensers should never be left out on the counter. Overspray can hit them. You've got exposed floss that could take bacteria from one patient to another. I hope that you'll go back into your office and that you'll look at some simple things that you might need to be doing. I love this picture right here because we've got a spoon from someone's lunch. We've got a disinfectant wipe. And I hope that you're going to look at protocols when you look at this. Remember that when we look at a disinfectant, we are never to go off-label use. I have yet to see a disinfectant that tells you to put cotton into a jar and pour disinfectant over it. If you do that, the studies that have shown us, including the one from Chris Miller, that told us that the bleach in the cotton can actually render some of the disinfectants inert and make them not work anymore. So if you know anybody that's still following this practice, please make sure that you make them aware. Because right now we're going to look at how you can establish a protocol for one of the most important things that's in your office. We're going to look at some products and we're going to talk about how they fit into this, and we'll even dissect a label and put it together so that you know what you need to be doing. Remember, as we look at cleaning and disinfecting, if we have debris on a surface, and I want to make sure you hear that, if we have debris on a surface, it is always 2 steps. One to remove the debris and one to disinfect. Now, what are we using to disinfect? We are using a pesticide. Remember that EPA hospital-grade disinfectants are pesticides. And yes, I did say pesticide. I'm going to really encourage all of you to go on to the EPA website and put in hospital-grade disinfectant and see what comes up with that. Hope all of you, though, are going to stop for a minute, keep calm, and clean and disinfect. As you go back to your office, as you have your staff meeting tomorrow, as you have your morning huddle, I hope that you're going to take some time to do some of the things that we're going to talk about, because we have got to stop what we're doing. We're going to stop what we're doing and take the time to check and see if we're doing it right. The Center for Disease Control, just a month ago, sent out a health alert for all of us. They have asked each of our office to stop what we're doing and make sure that we're following the protocols to keep our staff and patients safe. So let's go delve into what a hospital-grade infection disinfectant is and how we're supposed to be using it. Disinfectants are specially and specifically designed to be used on inanimate objects, inanimate surfaces, hard surfaces, and objects. They either destroy or irreversibly inactivate infectious virus, fungi, and bacteria. They are not necessarily taking care of spores, but that's not what we're worried about in our environment. We're more focused in on the specifics of what we would see in dentistry. So, directions for use. I want you to look and see on your disinfectant tomorrow what it says in that first part of directions for use. It is a violation of federal law to use this product in a manner inconsistent with its label. This product is not for use on critical and semi-critical medical devices. You are not going to use the product on devices that are supposed to be autoclaved, heat sterilized, or dental instruments, or specifically, the one that I am concerned about the most, handpieces. Our handpieces are all supposed to be heat sterilized. after every single patient. That has not changed. So what is the label? The label is all the experiments that they did on this product, and it is exactly what you're supposed to be doing in order to keep it effective and to keep people safe. It cannot be deviated from. This particular product, on the front of it, it says it's a one-step product, and it tells you for cleaning, disinfecting, and deodorizing. What an amazing product. Now, I think that this is important that we all train our staff to this product. On the product, it says that if there is no debris, you can clean and disinfect in one step. That is fantastic. It's a great move forward in all that we should be doing. But the part that I want you to get and understand that's very important for all of us is the next part that it says. It says if debris is visible, that we need to do two steps. We need to clean so that we can get access to everything, and then we disinfect. When we teach our staff how to do this, it's going to be great. I walked into an office recently and they were handing a patient a wipe. We don't want to be doing that. It's not intended for the patient to wipe their face off with. There's directions behind here about what you need to be doing. And remember that that OSHA has said that all of us need to be wearing utility gloves when we touch chemicals when we're not in patient care, when we're breaking that room down. So what is it I want you to look at about? How are we going to be checking things? Well, first of all, I want you to make sure that it is an EPA grade hospital disinfectant. And remember, this is ingredients of a pesticide. It's killing bacteria, viruses, spores, many things. And what the EPA is going to evaluate is the ingredients, where it's going to be used, how it can be used, the amount, the frequency, and the timing of use. Then they're going to tell you how it is discarded or how it is stored. On the back of your container, there's an amazing thing that you can take online and really look at closely. And it is the EPA registration number. It verifies when they approved it, tells you the number of when it was registered. The first set of numbers identifies who registered it. The second set of numbers is the product number. And the third set of numbers identifies who the distributor is, who can be very different than the other parts of that. If you need more information, and I'll give you a moment to write this down, this is going to go into, if you go on to EPA.gov, they will give you everything about the product. You just have to put the product name in. Some of the things that you're going to be training towards include things like the time weight average. Not every product's going to have a time weight average on it, but what a time weight average is how long can I be exposed to this product before it damages me, before it impacts my lungs, my liver, my kidneys. I have to be aware and train my staff to this. I have to make sure that everyone is going to be kept safe in the environment that we're working in. Some of the things you're going to want to look at when you're choosing a disinfectant, and I think the number one that I put on there every time has to do with time. I don't have a lot of time in between patients. So I have to know, and again, we talked about TB earlier and why we choose TB to be our marker cell. How soon will it kill TB? Does the product match the amount of time available between patients? You just looked at the product a minute ago that had a really great kill time. And looking at that kill time, it's going to make it so we can be more effective and yet things can flow in the direction we need them to flow. So what are the scope and of the claims on this? Does it clean and does it disinfect it at the same time? I've gone into a lot of offices lately where they've taken one product to clean and another product to disinfect, and they're not products that match each other. So when you look at this, I hope that you're going to look for a product that does both things. The product that we just looked at has both of those elements together so that you don't have to have two products and worry about, do they work together? Compliance. What's the shelf life and ease of handling? Does this product have a limited shelf life? Are we having to make it up every morning and dump it out every night? How is the product disposed of? One of the products that last year came out had some really big problems with disposal. You couldn't pour it down the drain, and you could use it on the surface. What are you supposed to do with it afterwards? Does a product require specific ventilation? There are products out there that are disinfectants that require you to have a fan going the entire time that you're using it. How much does it cost per patient to utilize this product? And am I saving money or losing money with it? If it's a wipe, is it costing me more than a paper towel or less than a paper towel? And how many paper towels am I having to use? What I have found in the studies that I've done is I end up using more paper towels, so it costs me more for the paper towel and the spray-on disinfectant, the spray wipe spray disinfectant, than it does for having a wipe. Is it safe for exposure for my staff to use, and what personal protective equipment is required? I will say one thing, that on a lot of the labels it doesn't necessarily tell us what kind of gloves we're supposed to be wearing, and it really doesn't matter if it tells us or not, because OSHA has been very specific about if we are working with chemicals, we have to wear sharps and chemical resistant gloves. So what works for you? I can't say for your office what works for you. We want to look at which pathogens are killed. We want to look at how many minutes required. We have to take, what I love to do is get a bunch of products when I go to the conventions, take it back, look at the smell, ask patients how they think about the smell. Does it have a nice smell? Is it easy to use? How is it going to impact the furniture we're working with? There's many things that we have to look at when we're doing this. So cleaning. What does it say on that label that we just looked at? It says, cleaning, use one or more wipes as necessary, wet surface sufficiently to thoroughly clean the surface. Disinfecting, to disinfect hard, non-porous surfaces, use one or more wipes as necessary to thoroughly wet the surface to be treated. And this is one of those wonderful things. 1 minute to achieve complete disinfection for kill of all pathogens listed on label. But here's the part where we've got to train our staff to start looking at this. For visibly soiled surfaces, clean before disinfecting. Allow surfaces to dry. For surfaces that may come in contact with food or potable water, rinse is required. I hope as each of you look at the different things that you're doing in your job, that you will think about setting up a protocol and a procedure, and anytime a new product comes into the office, that you'll review the label together. I'm going to answer any questions we have now. And the first question was about, I love that this came up, is why do we have to wear utility gloves? We have to wear utility gloves because we are being exposed to chemicals that can penetrate some exam gloves. And exam gloves are not the same thickness as utility gloves. And I'm not talking Playtex over-the-counter gloves that were made to do dishes. I'm talking something from a dental manufacturer that's got a thickness to it that's easy to use. I hope that you're going to think about that and really think about how important it is to follow up with that. Another question came up about what it stated on HIV. From the Center for Disease Control gave us those statistics on how long it can live outside the body. And those were in very specific conditions. And if you would like a copy of that report, I'm happy to send it to you. Normally, when we look at HIV, it does not live outside the human body for any length of time. But under certain circumstances, it can reside for a period of time. So that's what I was going off of there. So great question, and thank you for asking that. I want to thank you guys for being here with us tonight. You're going to have a little question and answer afterwards so that you can get your CE credits. So whether it's the middle of the night or the start of the day or the beginning of the day for you, thank you for being here today. Thank you for all that you've done to make dentistry a safer place for our patients. Thank you for cradling people in your lap, for making their smile a little brighter and their health a little better.